everyone. I'm in a hotel in Miami, and I wanted to make this tape for you to finish up the bladder pathology. We started up the initial topics, but I need to finish it up. So let's do these last couple of topics. Okay, urachal anomalies. And by the way, this I should not be there. It's like a little typo here. Something let's release that I. Let's get rid of that. So urachal anomalies. Well, the urachus normally is supposed to connect the belly button, the umbilicus, all the way to the bladder dome. So here's the bladder where the urine is. And so now the urine should be able to drain through here to the belly button and into the umbilical cord. So that's the urachus. Now, it's supposed to obliterate. It's supposed to go away, obliterate. So if it's still patent, this connection is still there to the belly button, that is called a patent urachus. Now, when this baby's born, what's coming out of the belly button will be urine. Urine coming out of the belly button. So as remember, urine, urachus. Urine, urachus, that's a patent urachus. Now remember, if feces are coming out of the belly button, meconium, we want to remember about a vitelline duct fistula. That's a connection to the ileum. So that's a little bit different. But again, we have two things coming out of the belly button here, feces, that vitelline duct fistula, urine, patent urachus. Now, what if it obliterates, but leaves little rests? Well, over time, those can dilate and become cystic. So you can get these urachal cysts, or if it's still connected out here, you can have a urachal sinus. But for the urachal cysts, it prevents one here and one here. If you have these cysts here, over time they'll dilate, and the mucosa will get irritated. So unfortunately, this can lead to glandular tumors like adenocarcinoma. So this is going to be an adenocarcinoma occurring at the top of the bladder dome. Now remember, the lining of the bladder is transitional. It's urothelium. So most bladder tumors are called urothelial cell carcinomas or transitional cell carcinomas. If you ever see a tumor at the bladder dome, the top of it, it's going to be adenocarcinoma. So I know for a fact that's something they're going to ask you. So most bladder tumors are going to be transitional cell, but if you see one at the dome, remember the term adenocarcinoma. For the rest of the urachal, a urachal remnant has turned malignant on you. Okay, that's bladder dome. All right, now let's move and talk more about the urinary bladder. Lots of interesting lesions here. Cystitis, inflammation of your cyst, of your bladder. Inflammation of your bladder. Now it could be acute or it could be chronic inflammation. Now symptoms, if I irritate the bladder, it's going to contract. So you're going to get frequent urination, frequency. You're going to get pain during urination, dysuria, and suprapubic pain. These are classic features you're going to find anytime there's inflammation of the bladder. Now, what usually causes inflammation of the bladder? It's usually infectious. It's infectious, particularly in women, because women have shorter urethras, so bacteria can make their way into the bladder through the urethra because it's shorter. So when a woman gets a bacterial cystitis, it's usually enteric bacteria. It's usually E. coli. Number one cause for bladder infections, number one cause for pyelonephritis, because it'll make its way up eventually into the kidney. So you got to treat bladder infections before they extend up into the kidney. You get pyelonephritis. Now, other organisms that can do it is Proteus, Klebsiella, and Enterobacter. Now, remember we talked about Proteus. It's a urea-splitting organism. So this can get up into the kidney and cause stones. Do you remember the magnesium ammonium phosphate stones? Yeah, it can cause those struvite stones for Proteus. And again, it's more common in women because short urethra, more cystitis, and then it can get up to the kidney and get pyelonephritis and stones. All right, now viruses can also cause cystitis as well. One I want to point out is adenovirus. Now I know, adenovirus, you think of the lungs, I know. But adenovirus can also involve the bladder. And when it does, it can give you a hemorrhagic cystitis. So not only do you get the pain, but you're going to have some blood in the urine. Now, radiation can also damage the bladder and cause cystitis too. So why would I be radiating that area? Oh, because the cervix is nearby. I'm not radiating the bladder. I'm radiating the cervix for cervical cancer, and the bladder is just nearby. So unfortunately, when you do cervical cancer radiation, you can radiate the bladder and get cystitis. For men, it would be prostate. But prostate. Remember, the bladder sits on the prostate. So if you have prostate cancer that's unresectable, I will radiate the prostate, and I'm going to hit a little bit of water. So you get a little radiation cystitis there as well. Now, one more thing can cause cystitis, and those are drugs, especially cytotoxic and anti-tumor drugs. Now, the classic one for exams is the alkylating agent cyclophosphamide. This is notorious for giving you a hemorrhagic cystitis. Now, the reason for this is cyclophosphamide will be activated by your liver. It's not active yet. When I give you cyclophosphamide, the liver cytochrome P450 system is going to activate it. This is going to turn cyclophosphamide into the active metabolite. The active metabolite is called a nitrogen mustard. Nitrogen mustard. No, not the stuff you put on a hot dog. No, this is mustard gas, like for World War I. This is pretty toxic stuff. Well, this is going to irritate. This is going to cause it's going to damage cells. It's not going to irritate them. It's going to mutate and alkylate the DNA. This is called an alkylating agent. It puts an alkyl group on the DNA, causing cross-linking. Well, if I damage DNA, I'm going to kill cells. That's why it's a chemo drug. It kills cells. It kills the cells because it damages the DNA by alkylating DNA. Now, when it gets activated, there's a metabolite, and that metabolite will irritate the bladder and cause cystitis. This metabolite is called acrolein. Acrolein. So if you look in first aid, you'll say, oh, hemorrhagic cystitis. Yeah, but they don't always explain it. I hope they do. I gotta look into it again. But acrolein is the metabolite that is made by the liver. When you break down cyclophosphamide, it goes into the urine and it irritates the bladder. Acrolein. That's what causes the hemorrhagic cystitis. So to prevent this, because doctor, do no harm. I don't want to put somebody on a drug and watch them pee blood. That's not cool. So we're going to give Mesna. Always give Mesna whenever I have to give high-dose cyclophosphamide. Oops, camera came off the page here. Move it over a little bit. There we go. Give Mesna. Mesna will bind the acrolein. It literally binds it and prevents the irritation of the bladder. So this is an easy thing to ask on U.S. Assembly exams. Anytime I give high-dose cyclophosphamide, give Mesna to bind the acrolein. Now, one more thing I want you to know about acrolein. Not only does it irritate the bladder and cause inflammation and hemorrhage and cystitis, but it also irritates the bladder. So long-term, you're at risk for bladder cancer. So this is one of the risk factors for transitional or urothelial cell carcinomas. So very important to know about acrolein. Anybody with cyclophosphamide in the past is at risk for bladder cancer. All right, now there's some special forms of cystitis, some really unique ones. Now the first one is called an interstitial cystitis, also known as chronic pelvic pain syndrome. Now think about that, chronic pain in my pelvis. This is very uncomfortable. This is not cool. So this is a persistent, painful form of chronic cystitis. It's much more common in females, although males can get it too. And what they're going to have is from time to time, they'll have intermittent suprapubic pain in the suprapubic area. They'll get frequency dysuria. They'll get pain during intercourse, dyspareunia. Ooh. And every once in a while they get hematuria. Well, John, this sounds like an infection. This sounds like infectious cystitis. Yeah, but you look for bugs and you can't find them. You can't find them. You check the urine, cultures are negative, RAM stains are negative. You can't find any bug. So again, that's the key. It looks like a chronic infection, but you can't find any organisms. And when you put a scope in, you'll see the mucosa often has areas of fissures and then there's some punctate hemorrhage. So clearly it's being irritated, but there's no bacteria we can find. Now, how is all this inflammation going to heal? Long term, you're going to get transmural fibrosis. All scars contract. So eventually you're going to wind up with a contracted bladder. That's not cool. When you have a contracted bladder, you have to pee every like 10 seconds. Not a good thing. So again, we really don't understand this disease. It's a chronic inflammatory condition. We just don't know why. It's like a mystery. It's a mystery condition. We don't really understand it. Now, the next one is also kind of interesting for exams because it's a buzzword. There's an easy buzzword. If you get the buzzword, you'll get it right. This is called malakoplakia. Now, plakia is a plaque. So you'll see these plaque-like lesions inside the bladder. Now this is due to defects in phagocytosis, so the macrophages either have trouble eating or they have trouble digesting. It's kind of like indigestion of macrophages. Now the reason for this is usually because of immunosuppression. So there's something wrong with your immune system. So either immunosuppression or maybe an autoimmune disease, your macrophages are just not working properly. They're like eating bacteria, but then you can't digest them. So it's like indigestion. So what happens to the bacteria? Well, they accumulate. The little broken down pieces accumulate, and they get calcified, and they become these bodies, these calcified bodies. So you'll see inside the macrophage, phagocytes that are gorged with undigested bacterial products. When they start to calcify and get large, and I can see them under a microscope, we give them a fancy name, Michaelis-Guttman body. As soon as you see that, Michaelis-Guttman, Malakoplakia. Michaelis-Guttman, Malakoplakia. Because these are basically calcified deposits in the phagosome. It's always calcified, dead bacterial products that they couldn't just break down, they couldn't get rid of it. So it calcifies, so it's basophilic into fluids, calcium. It's layered, it's got lamellar appearance, and it's concretions. It's a mineralized concretion inside the macrophage. Now again, let me show it to you. Woman's gonna come in with cystitis. We put in a scope and we see these plaques. We biopsy the plaque, and here's what we say. In the submucosa, we're gonna see these macrophages. Now notice all the abundant pink junk in the cytoplasm. You saw the pink junk in the cytoplasm? These macrophages are just packed with junk, just packed with it. Now they start to calcify, turns purple. These are calcifications, see they're round, they're like little concretions, like little stones. This is the Michaelis-Guttman body. So basically, just macrophages that are having indigestion. So Michaelis-Guttman, Malakoplakia. One second diagnosis, and again, look for an immune problem. Look for immunodeficiency, look for some sort of autoimmune problem. Their immune system's just not working right. They're not digesting. All right, now there's two more forms of special cystitis. This one's kind of interesting, polypoid cystitis. So inflammation that makes the mucosa become edematous and it raises like a polyp. So it's an inflammatory condition due to irritation, and you'll see marked submucosal edema. When you get edema, you get these broad, bulbous polypoid projections. So if here is the mucosa coming along, all of a sudden you'll see this swollen, bulbous projection, big old polyp-like lesion. Now, why do I care? Well, you care because bladder cancer is papillary. So this is going to mimic the significance of this condition. Is when I look in there and I see all these, I'm going to think it's a bladder tumor. But you biopsy it, it's mucosa that's inflamed. That's all. It's edematous, swollen mucosa. That's all. It's all it is. It's not cancer. Now, it's often associated with an indwelling catheter. Does that make sense? That makes sense. The catheter's coming in here. It keeps hitting this mucosa. Well, if it keeps hitting the mucosa, this area becomes edematous. It swells up. And you get this polypoid lesion. And the next day, it kind of moves, the catheter moves over here and irritates this area for a while, and you get a polyp there. Now, again, the significance is it looks like papillary urothelial carcinoma, but it's benign. It's just inflamed, swollen mucosa. Now, how about this one? Von Burns next. Von Burn. It sounds like it should be related to Dr. Doom. Fantastic Four, Von Doom. Here's my brother, Von Boom. It sounds like it should be a comic book villain. Von Boom's next. Another name for it is proliferative cystitis. So inflammation, but this proliferation of the urothelial lining. When it proliferates, it grows down. It grows downwards. So here's my epithelial layer. And then this area starts to proliferate and grows down. So you'll see these nests of normal mucosa down in the submucosa, lamellopropria submucosa. So it's basically downward growth of urothelium into the lamellopropria. And it's just these nests of benign appearing urothelium. Now this is the key word here, benign appearing epithelium. Because guess what bladder cancer is going to do? Bladder cancer is going to invade into the wall too. But bladder cancer, when you look at it under the microscope, you see nests of malignant appearing urothelial cells. So that's a very important clue here. We're going to see nests, like collections of benign mucosa down here. Sometimes you'll see the connection with the mucosa, sometimes you won't see the connection. There's a connection, you can't see in this plane. These are called von Brunn's nests. That's inflammation leads to proliferation. Now, it usually increases in frequency in age. So I see this in older people a lot more than younger people. And we see it very common in the trigon area. That's usually where we see it. Now, when it undergoes changes, when it gets metaplasia, it gets cool names. I thought von Brunn's nest was cool enough, but sometimes the epithelium will turn to cuboidal or columnar. Well, columnar is more like glands. So we'll call it cystitis glandularis when these nests start looking like columnar glands. So you start seeing these columnar cells lining it. Looks like glands. Again, they look benign. They're just metaplastic, turn to glands. Now, what if it turns to goblet cells? Well, goblet cells are the intestines. So this is called intestinal metaplasia. Now, question. Do you think intestinal plasia of the esophagus goes to adenocarcinoma? Yeah. Does intestinal plasia of the stomach go to stomach adenocarcinoma? Yeah. Does intestinal plasia of von Brunn's nest go to adenocarcinoma of the bladder? Yeah. And if that's the intestinal plasia, it's not where it should be. It can go bad. So we have two things now. When I see a lot of intestinal plasia get adenocarcinoma, or if you see a mass in the bladder dome, that's a urachal remnant that turned to adenocarcinoma. Okay, so two adenocarcinomas you better know. Finally, what if the epithelium becomes flat and it's basically cystic? So the epithelium is really flat. So it looks like a giant cyst. Then we call it cystitis cystica. Cystic von Brunn's nest. They're cystic now. So again, we just give it fancy names when it undergoes different types of metaplasia. It's still benign. Benign appearing epithelium below the normal mucosa. It's in the lamina propria. That's von Brunn's. All right, now let's get to money. Bladder cancer is something you need to know. It's actually increasing in America. We need to know about it. Now, it's more males than females, and they tend to be older, 50s, 60s. Now, it's much more common in developed nations than in underdeveloped rural nations. And it's more common in city dwellers, urban environments, much more than rural. Now, probably a big reason for males and developed in this is because the number one risk factor is smoking. Males smoke more than females, although female teenagers are trying to catch up, right? Women are trying to catch up. Teenage females are picking up smoking at a high rate. But still, men are still more commonly smokers. So that explains why it's men, more in urban areas, in developed nations, although we're sending cigarettes to underdeveloped nations too. But cigarette smoking, major risk factor, because all the carcinogens are concentrated for excretion in the kidney. So you know, increased risk of kidney cancer. Goes into the urine, into the ureter, increased risk of urinary cancer. Gets stored in the bladder, increased risk of bladder cancer. So everywhere along the way can get cancer. Okay, so it's a big risk factor. Now that's number one by far. The other risk factors are kind of rare but testable. So if you're working in an occupation where you're working with dyes, aniline dyes, like beta-naphthalene, as a beta-naphthalene leads to urothelial cell or transitional cell carcinoma because it irritates. So that's the dye industry, like dyeing shirts, dyeing rubbers, dye industry. Now, beta-naphthalene is also present in mothballs. So little Timmy's crawling in your grandma's closet, he can smell these mothballs and eat them. If he eats mothballs, he's eating beta-naphthalene. And it's poisonous to moths, and it's poisonous to your bladder too. Now, we mentioned cyclophosphamide. Remember the acrolein causes cystitis, but it can also irritate and cause cancer long term. Another drug is phenacetin. Phenacetin was never really caught on in America. It was mostly used in Europe. So I don't know why it's on US MOEs, but if you ever hear phenacetin, it's an analgesic, a pain relief medicine that was not really very popular in America, much more common in Europe. But if you abuse phenacetin over time, all those little byproducts irritate the bladder. What about irradiation? If I radiate the bladder because I'm trying to hit prostate cancer, well, obviously that can lead to dysplasia and cancer. And then one more, if you're swimming in the Nile River, another place in Africa too, you can get schistosoma. Now, hematobium, see it's got a B in it? That's the one that goes to the bladder. Manson eye, got an I in it. It goes to intestines and liver. So Manson eye goes intestine, liver, gives you a fibrosis of your liver. But hematobium goes to your bladder, irritates it, and when it irritates it, you get squamous metaplasia. So this one leads to squamous cell carcinoma because of irritation. You get squamous metaplasia and then squamous cell carcinoma. Kind of rare, but if they're coming from Egypt, swimming in the Nile, think it's just the cell hematobium. All right, I want you to look at this picture. We put a scope into the bladder. Now, do you see this kind of polypoid little fingers here? Polypoid mass here, another polypoid mass. And you can see little polyps in the bottom, polypoid masses raised. Well, it looks like some plaques here. This might be dysplasia here. So this is a polypoid too, that's what they look like. Now, transitional cells, the urothelium, lines everything from the renal pelvis, the ureters, the bladder, part of the urethra, so you can get these cancers anywhere from the renal pelvis to the urethra. The entire lining can get these same tumors. Now, obviously, the largest surface area is the bladder, right? The ureters, kind of small, not much surface area. They're long, but not much surface area. Renal pelvis is a little bigger, but bladder's got the most surface area. So they can occur anywhere, but most likely these tumors are going to occur in the bladder because of the most amount of surface, and all the urine's just sitting there, like day and night. So yeah, bladder's the most common site. Now, clinically, if I have a bladder cancer, most common presentation, painless hematuria. Now remember the differential. The differential painless hematuria is the largest differential in medicine because it could be my kidney bleeding, could be my bladder, could be my urethra, could be my prostate, could be my ureter, could be anywhere along the way. So often we're going to have to either do cytology to look for malignant cells, or we're going to have to put a scope in the bladder to see these masses. Because painless hematuria is one of the most common presenting findings, and the differential is huge. Now, it can also cause obstruction, so you can wind up with urinary tract infection, and even polynephrititis. If it expresses the ureters, you can get polynephrititis. Now, the malignant cells will be shed, so you can detect them by doing urine cytology. So again, cytology and looking in with a scope or it's going to be required to pick this up. Now, problem with bladder cancer is it's often multifocal and it often recurs. Yeah, look, get 1 year, multifocal. And the reason for that is, which part of the bladder is the urine touching? All of it. As you walk around, squishing it, but it's all over ways. When you're standing up, it's mostly down, but it switches around. Then you lay down, now it goes on the back wall, you roll on your sides. The urine's touching everything. So we give this a term. We call this the field effect. The carcinogens in the urine are touching the entire area. The entire area. So therefore, everything is getting mutated. So therefore, you can get a tumor here, and then a few months later you get a tumor over here, and a few months later you get a tumor over there. So they often get multifocal, asynchronous. You get one now, you get one in 2 years, you get one in a year later. So unfortunately, once you have a bladder tumor, you have to watch the whole bladder forever because it's a field effect. That's what they mean by multifocal and recurrent. The whole field is damaged and involved. Now the key for these tumors though is how deep does it invade? That's the key. So depth of invasion and staging are the most important factors, right? Staging is always important for tumors, but for this one, the depth of invasion determines treatment. Is it superficial? We're treating superficially. But once it invades the detrusor muscle, cystectomy time. Not a good thing. You don't want to live in that bladder. It's not cool. All right, now the types of bladder tumors, by far the most common, is the normal line of the virus transitional cell. So transitional cell carcinomas are the most common type. Now, when I was in med school, they called it transitional cell lining. Nowadays, they changed the name. They call it urothelial cell lining. All right, I'll play the game. The most common tumor is transitional cell carcinoma, but now we call it urothelial cell carcinoma. All right, I'll play the game. So urothelial carcinomas are the most common type by far. Now, if you're swimming in the Nile, That's when we're going to start thinking about squamous. This is common among Egyptian friends, and it's associated with schistosoma infections, which lead to inflammation and therefore metaplasia. So you get metaplasia to squamous, then you get invasive squamous cell with the keratin pearls, the keratin whorls, all that stuff that we see for squamous cell. Now, just for fun, I just want to list this right here. When you get squamous cell, it's usually people from Egypt. So they're swimming in the Nile. So what is the intermediate host of schistosoma? Well, it's the freshwater snail. It's Galley. It's the freshwater snail. That's who carries schistosoma. That is the intermediate host. So schistosoma is going to hang out in the snail. Then it gets released, and it free swims. It swims by itself up to your leg, because you're standing there in the Nile, swimming in the Nile, there's your foot, funny looking foot. Now what it does is it swims right up to you and it penetrates your skin. There's not many bugs that can get through intact skin. Most bugs need a cut to get in, not schistosoma. Schistosoma has enzymes that will digest the keratin and go right through, penetrate right through the epithelium. Now, once it gets into the bloodstream, where does it go to lay its eggs inside of you? Well, it depends. Hematobium goes to the bladder and lays the eggs in the bladder. Mancinite goes to the intestine, liver, lays its eggs there. So if it lays in the liver, you're going to get pipes and fibrosis. You're literally going to damage and get cirrhosis. Now, to remember that, there was a famous Egyptian singer. If you have any friends from Egypt, they will tell you. He was like Frank Sinatra of the Middle East. Frank Sinatra, he was a good-looking guy. He was in movies. He was a singer, just like Frank Sinatra. Really great singer. Well, guess that? He grew up in Egypt. So as a kid, he's running around. He got schistosoma mancinite. It went to his liver, laid eggs, and he got fibrosis of his liver. So what happened to him? He started vomiting up blood. The #1 killer of cirrhosis is ruptured esophageal varices. He ruptured his esophagus and he bled to death. Bled to death. #1 killer of cirrhosis. Now, he was such an amazing singer that when they brought his body, they brought the casket through downtown, women were going to the top of the buildings. I can't live without it. And they would jump. As I went by, they would jump off the building. It'd be like if Justin Bieber died. I know you'd all go to the top of the IU, and I can't, I'm not believing it. No, he's not worth it. But it'd be like something like that, like when Kurt Cobain died, or was cutting themselves. Well, that's what happened. This guy was so amazing, such an amazing singer. Now, for hematobium goes to the liver, it goes to your bladder and lays eggs there. Now, this inflammation leads to metaplasia. So now you're going to wind up with squamous cell. Squamous cell because of squamous metaplasia. So I want you to roll like this. Are you ready? In ancient Egypt, I'm talking like hieroglyphics, ancient Egypt. Back in ancient Egypt, they thought men had periods too. Yeah. There's actually hieroglyphics of a guy peeing red. He's peeing red. Because in the old days, the men would be in the river trying to fish, get food for the family. They'd be throwing nets, they'd throw spears, they'd try to catch fish. Well, if they're all in the river, they're going to wind up with schistosoma. Yeah, when it gets to the bladder, it irritates them. Every once in a while, they go to urinate, and there's blood in the urine. The guy's like, ooh, blood in the urine. Must be my time of the month. But it's not fair, ladies. Guy gets a period, no cramps, no mood swings, no psychosis, just blood in the urine. It's not fair. Guy gets a period, that's a good one. They thought men had periods. That was the man's period. That's what they thought. Crazy, huh? So I want you to write this. Ready? What letter is this? S. S. S for schistosoma. S for swimming in the Nile. S for the intermediate host, snails. And finally, S for what kind of cancer? Squamous cell. Walk like an Egyptian, walk like an Egyptian. Got it? So it's kind of silly, but when you see somebody from Egypt on the exam, think schistosoma. And don't forget, eosinophils are needed to kill parasites. So in this bladder, you see inflammation with lots of eosinophils. Do you remember why? Because eosinophils have major basic protein. Major basic protein is toxic to parasites. So always remember this, must bust parasite, must bust parasite, major basic protein, must bust the parasites. So kind of a silly way to remember eosinophils, you'll see them in parasites. That's what kills parasites. Now, here's a nice question. We're in Egypt and we want to reduce the amount of bladder cancer that we're seeing. What could we do to decrease the amount of bladder cancer in Egypt? Control the snail population. Don't kill the snails, we need snails, but let's control their population. If there's less snails, there'll be less intermediate host for schistosoma. So I think that's a really good question because it shows me you understand where schistosoma comes from. Very good. The intermediate host is the freshwater snail. All right, now that's kind of a rare tumor, but remember it. And then one more, adenocarcinoma, 2 times you're gonna pick it. If there's a urachal remnant, so you have a tumor in the bladder dome, the top of the bladder, big adeno every day of the week. That's a tumor of the urachal remnant. Or you pick it if there's extensive intestinal metaplasia. Intestinal metaplasia is going to turn to glandular tumor, adenocarcinoma. So again, 3 major bladder cancers, by far transitional urothelial cell is the most common. They're from Egypt, you think squamous cell. And of course you want the adenocarcinoma if there's a urachal remnant or intestinal metaplasia. By the way, this metaplasia can also occur when the bladder's open. Do you remember when we had extrophy? The bladder was open to the environment. What's going to get irritated? You're going to get intestinal metaplasia, you're going to get adenocarcinoma. That's another example of when you get intestinal metaplasia. All right, now genetics. There's a big difference between superficial tumors and the ones that invade deep. The ones that are superficial are usually initiated. They're caused by deletions of tumor suppressor genes on chromosome 9, particularly P16. Now we've seen this one a couple times. P16, we see it with melanomas. We've seen it with a couple other tumors too. So P16 is an important minor break on the cell cycle. Now another mutation that's often found superficial is mutations in fibroblast growth factor receptor number 3. Now we're going to see this again later on when we talk about bone lesions. There's going to be a couple of bone lesions that have fibroblast growth factor. And then of course activating mutations in RAS. There's an oncogene. It's going to cause proliferation and growth. So for superficial tumors, P16, epidermal growth factor, and RAS. Now what about really invasive tumors? Well, those are bad. They're invading. What are the bad genes we always think of? For really invasive, yeah, you want to think of that knockout of RB and P53. He knocked out the guardian of the genome. He knocked out the guardian of the cell cycle. Well, guess what? You're going to get very malignant tumors. Okay, so that should be easy to remember that. All right, now let's talk about precursors to invasion. So before we get invasive disease, we have non-invasive disease. We've got 2 things. We've got non-invasive papillary tumors, see the papillae, not invading anything. It's just growing upwards. And then we have flat urothelial carcinoma in situ. See, it's flat, hasn't invaded anything. It's just flat carcinoma in situ. Eventually it becomes invasive. Invasive tumor. But I want to go back and some of the precursors. Before you get invasion, you can get papillary tumors. Now these are called exophytic. Endophytic means going in to your mucosa. Exophytic means going up and out. So exophytic, papillary-like projections, that's classic. Now there's a couple of forms. The most bland one is called the papilloma. It looks like normal mucosa just thrown up. It all goes thrown up into little papillae forms. Looks totally normal. Then you start to see some low-grade dysplasia. We call this low-grade papillary urothelial carcinoma. Then you get high-grade dysplasia. We call it high-grade papillary carcinoma. But again, no invasion yet. No invasion. These are pre-invasive lesions. It's kind of like in situ, right? Now, another way it can occur is it can occur as flat lesions, like plaques. So papillary things are easy to say. Flat plaques are a little harder to say. This is called carcinoma in situ, just thick plaques. So on gross, we'll see red, granular, thickened mucosa. So when I go back to this picture here, So these are the this tumor nodule, tumor papillae. But do you see these red areas here? These are probably high-grade carcinoma in situ. That's probably where it came from, carcinoma in situ. That's red granular plaques. All right, now under the microscope, it's not invasive, but the tumor cells look ugly. Yeah, you're going to see malignant cells. They lack cohesiveness. They're not sticking together. They're just kind of discohesive, falling apart. And it's often multifocal. Again, field effect. Now, the problem with the carcinoma in situ is if you don't treat it, the majority are going to progress to invasive cancer if you just leave them there. So we got to treat these when we see them. Now, eventually, both of these lesions can become invasive. When they do, they invade the lamina propria, and eventually they can go into the muscularis propria. Oh, that's the key decision point. Before it goes into, if it's just here, the mucosa, submucosa, it's superficial treatment. Once it goes into this muscle layer, like this one, once it's in the muscle layer, now I have to do a cystectomy. Not cool, not cool. So again, you can have these invasive papillary ones, start out papillary, and now it's becoming invasive. We can just have the flat ones that just directly invade. The key is how far does it go in? All right, now let's take a look at some of these lesions. Here is the benign papilloma. Doesn't it look like normal urothelium? It just got papillary structures. You got this fibrovascular core. See the blood vessels in the middle? Fibrovascular core. So it's like a finger. We're cutting it on cross section. So we're seeing it on cross section. Looks cut through it. This is the fibrovascular core. On the surface is epithelium. Now, how many layers are you supposed to have? 5 to 6. Let me see. 1, 2, 3, 4. Normal number. Normal number of cells. Nuclei are small, they're bland looking. Look, there's an umbrella cell layer. See the flat umbrella cell? So it kind of looks like normal mucosa cell. Normal appearing urothelium, just in a papillary projection. That's a papilloma. Okay, good. Now look at this one. This is called low-grade papillary urothelial carcinoma. What's the difference? Well, here's the central papillae, right here with the blood vessels and the fibrous core. That's the central. Now look at how many layers. That's more than 5 to 6. That's way too many. So this is why it's carcinoma. There's too many cells. Notice the nuclei is getting bigger than it was before. They're not very atypical, but they're bigger than they were before. And I want you to notice the mitosis. Where should mitosis be? In the basal. They should be down here. And the cells are supposed to proliferate from the basal, the stem cell layer. You see mitosis up there? That's abnormal. So again, this is a low-grade papillary urothelial carcinoma. Again, not invasive yet. This little papilla is sticking up. Now, what about this one? Here again is the fibrovascular core. There's the core. Now again, look at the cell layers. It looks like there's more than 6 here, so there's increased number. But look at the nuclei. Compared to the small, bland ones, these are big, hyperchromatic, dark, ugly looking. Look at this one. This one, there's a tumor cell in Pittsburgh. Look at the size, huge. So again, we're seeing nuclear variation, we'll see mitosis, and it's kind of discohesive. It's not sticking together. You got these spaces here. It's not sticking together as good as it should. So this is called high-grade papillary urothelial carcinoma because you're getting marked cytologic atypia. So too many layers plus very atypical cells. Now again, is the board going to ask you, here's a picture. Is it a papilloma? Is it low grade? No. I'm showing you this because I want you to know, what does it mean, low grade? What does it mean, high grade? They're never going to ask you to grade it, but they'll ask you, what does it mean? If it's high grade, what does it get? Well, low grade's better, high grade's worse. But again, as long as it's not invasive, local treatment. Local treatment for that, that, and that. All of them get local treatment. So telling them apart is not really that important. But I like to do it because I'm a pathologist. That's what we get off on. You, as a clinician, you don't care. It's papillary, it's not invasive, okay, now I know what to do. Local therapy. If it's invasive into the muscle, all right, now I do the cystectomy to get the surgeon in. So that's what you care about as a clinician. But I would be a terrible pathologist if I didn't get excited about this. All right, now let's take a look at the flat lesions. Here's the normal urothelium. Again, you should have 5 or 6 cells, 1, 2, 3, 4. And then on the top should be a flat umbrella cell. Beautiful, flat umbrella cells, flat cells on the surface. So this is what normal urothelium looks like. Now look at this, much thicker, a lot more layers, And look at the nuclei. They're bigger than they are here. They're bigger and more typical. Notice that the spaces around the cells, they're not sticking together. They're kind of discohesive. So this is called flat carcinoma in situ. Look, in situ, base of membrane, no invasion here. In situ, local therapy, all good. So we see a large pleomorphic nuclei. We see a loss of cohesiveness, and you're going to start seeing mitoses, again, above the basal layer. That's a mitosis there, the one I circled. It's above, it should be down here. Mitosis should always be in the basal layer. But now you're seeing it up here, that's totally abnormal. So again, flat carcinoma in situ. Now, where it invades, same treatment. The only difference is it when it invades into the muscle. That's when you change your therapy. All right, so we put it right here to make the diagnosis. Two things I want to do to see this tumor. I want to check the urine to look for abnormal atypical cells, and I want to do cystoscopy with biopsy. I want to look in, see those papilla lesions, biopsy them, some plaques, biopsy them. I want to see what's there. Now, treatment. For superficial, non-muscle invading tumors. It could be invading, but not the muscle. So superficial, non-invasive tumors, local therapy. Local. So you could put a scope in and do a resection, grab all the visible things, pull them all out, get them all out. Number two, I can inject chemo into your bladder. We call it intravesicular, that's inside the bladder, intravesicular chemo. Just put the chemo in there, let it slosh around, kill everything. Cool. Now, that's not the sexiest this one. Topical immunotherapy. Get the immune system to kill it. Do you remember the BCG vaccine that people use to prevent TB in other countries? BCG, it's a bacilli-like TB. Well, we're going to inject it, BCG, into the bladder. Now, when I put these bacilli into the bladder, you're going to get granulomas all over the place. Now your immune system's activated, and those granulomas will destroy all the dysplastic, all the neoplastic stuff. It'll kill everything. Get your immune system. That's brilliant. Granulomas all over the place. So again, if it's local, we treat it locally. Resect it, intravesicular chemo, intravesicular BCG. Now remember, we have to follow, because field effect. You often have recurrence, multifocal, you gotta keep watching. So we'll keep doing scoops, and we'll keep doing urine cytology for the rest of your life, because you can always come back. Now the problem is if it invades the muscle. Once it invades the muscle, now you have to do a radical cystectomy. Yeah, so that's done for three reasons, but the big one is tumor invasion of muscularis propria, the detrusor. So I made a big deal about localizing and know what it's about. Now you also have to do it if there's carcinoma in situ or high-grade papillary cancers that do not respond to local therapy. If the BCG doesn't work, I can't resect. Well, then you have to resect the bladder if the local therapy fails. Now you're also going to have to do it, cystectomy, if the carcinoma in situ extends into the prostatic urethra and glands, because the chemo is not going to get into the prostate and glands. It's going to stay in the bladder. So unfortunately, if it goes into your prostate, we often have to do cystectomy too. So we want to see how far the tumor spreads. Now, if it's advanced in locally invasive disease or metastatic disease, now we're going to give systemic chemo, not just inside the bladder. We have to give systemic chemo for metastatic. Metastatic is hard to cure. So we really got to cure this before it spreads. Okay, feel good about bladder? Bladder tumor is very high yield, very testable. So let's do a quick review here. This is the bladder chapter review. I like doing these little summaries for you. Okay, now last time we talked about what is the most common cause of obstruction and hydronephrosis in infants and children. Well, do you remember where the pelvis and ureter meet? They often have a little obstruction there. So we call this ureter-pelvic junction obstruction. Yeah, this is important. Oh, by the way, this is also associated with a kidney disease. Do you remember multicystic dysplasia? multicystic, we see the cyst and the cartilage and all these like, weird things. Well, that can often have this narrowing at this junction as well. All right, how about this one? What's the fibroproliferative inflammatory process that leads to hydronephrosis? Fibrosis of the retroperitoneal. Oh yeah, retroperitoneal fibrosis. Remember, this is associated with the IgG4 related diseases. So they often get fibrosis of the mediastinum, they often get autoimmune pancreatitis, and they often get fibrosis of the thyroid gland too. Okay, these associated diseases. Look for high IgG4. All right, how about this? Pouch-like evagination of bladder wall that increases the risk of urinary tract infections. Little outpouchings, a little diverticuli, you mean? Yep, bladder diverticuli. Urine just sits there like a culture plate. You can get UTIs. And again, that's often due to back up at high pressure, like BPH. BPH can't get out, pressure backs up. What is the most common cause of infectious cystitis? Well, for infectious cystitis, we want to think about colonic bacteria. So enterobacteria like E. coli is number one. Number one for bladder infection, number one for kidney infection. All right, now what drug was it that caused the hemorrhagic cystitis? Well, adenovirus can do it, but for drugs, I want you to remember cyclophosphamide because of acrolein. All right, what are you going to call your intermittent suprapubic pain, urinary frequency, dysuria, pain during intercourse, and hematuria without a bacterial infection? Because I was about to say infectious cystitis, but then there's, that is chronic pelvic pain, also known as interstitial cystitis. Not a very cool thing to live with, chronic pain in my pelvis. All right, one second diagnosis, McKellis-Guttman body. Oh, those cows are in the macular indigestion. Oh yeah, that's called malakoplakia. Malakoplakia, McKellis-Guttman. Malakoplakia, McKellis-Guttman. Very good. All right, how about broad bulbous projections of inflamed urothelium? Well, that's cystitis. But what kind of cystitis would you call it? It's got polypoid. I'd call it polypoid cystitis. Again, it can look like papillary tumors, so we often, if we see it, we'll put the biopsy to see what it is. Just inflamed because edematous. What do you call when you have downward growth of the urothelium into the lamina propria, but it's benign appearing? Well, that's called funburns. Funburns, that sounds evil, but no, it's just downward growth. And then you get all the cool metaplasias, right? The old cool type metaplasia. Okay, what do you call it when you have a tumor of urachal at the dome of the bladder? That's called adenocarcinoma. The rare times you'll see adenocarcinoma, bladder dome. All right, what are some risk factors for bladder transitional cell carcinoma? Well, risk factors is many, but the number one is smoking. Remember smoking. Remember beta-naphthalene. Remember cyclophosphamide, phenacetin. And if you're from Egypt, remember schistosoma and squamous cell. All right, what about the topical immune therapy used for superficial bladder cancer? Intracerebral BCG. Inject it, you'll make granulomas, and the inflammation will kill the tumor. Wow, that's so cool. Finally, what is the treatment for transitional carcinoma? Transitional cell invading the detrusor muscle? Cystectomy. Now, when I take out your bladder, I gotta make a new one using intestines. What a mess. I take a second intestine, I try to make a new bladder, test the ureters. It's really a mess. It's a mess. So you like bladders are good. Bladders are very important. All right, gang, we're done with the meta section. I'll see you the next day.